Ladies and gentlemen, now with great pleasure that I invite Sunil to the podium. Sunil is a UWI graduate, member of the College of Obstetric, member of the Royal College of Obstetricians and Gynecologists of the UK, a South-based obstetrician who was the head of department in the San Fernando General Hospital until he took up the job as lecturer in Obs and Gynae in the University of the West Indies. He's a leader. Because of him, we are well connected to almost 100 people online, and he's extended his reach all across the Caribbean to have all the other faculties, all the other campuses joining into this conference. I welcome Sunil.
So thanks again for having me be part of this important initiative. Before I start, 2 slides that Professor Nelson Piercy had earlier that had diametrically opposite reactions from me. The first was one that brought back some nightmares when she had the slide with those physiological changes of pregnancy, and we had to all remember those for our MRCOG, and really it was an awful memory brought back there for me, Kathy, but I'm sure everybody can relate to that as well. The second, it's unfortunately Minister is gone, is that slide where you have the change of goalpost, so to speak, with the tachycardia, uncomplicated tachycardia for pregnant women, because we do over-investigate some of these women with CTPAs, something that is certainly not inexpensive, and is a drain on our resources here. The other thing along those lines you mentioned as well would be our neurology or neurosurgery colleagues, and the frequency with which we do MRIs for headaches in pregnancy is quite alarming. And again, an uncomplicated headache in pregnancy is something that is very, very normal, and it is something that we need to look at. And I think with those 2 slides, you would have saved Trinidad and Tobago a significant amount of financial resources. So let me start by saying this is the West Indian Society for Obstetric Medicine, not the Trinidad and Tobago Society of Obstetric Medicine. And these are our main campus sites. I'm happy to have our dean here. He'll be pleased to know that we are joined by some of our colleagues in Jamaica, where we have the Mona campus, where I graduated from Ingrid as well. I was there. We have the Cave Hill campus. I also worked in Cave Hill and have some very close friends there. Of course, St. Augustine, which is Trinidad and Tobago. And we have the School of Clinical Medicine and Research at the Bahamas. And we do clinical training there, not pre-clin, but clinical training for the medical faculty. So what's being done? Obviously, we need to know what we're doing now before we can chart our course with our obstetric medicine journey. We have a population of approximately 6 million in the English-speaking Caribbean, mainly Afro-Caribbean, followed by Indo-Caribbean, particularly in Trinidad and Guyana. Caucasian, Chinese, mixed race will make up the rest. And as we all know, our population are at significant risk of certain medical conditions, particularly hypertension and diabetes, and specifically sickle cell disease in Jamaica. I know Sanju and Ingrid would be quite well aware of that, and they will probably see those in the London population as well, I would imagine. Our healthcare system, and the structure of it is similar to that of the British system, the NHS system. Of course, we are much more resource restricted. So our colleagues, I did reach out to our colleagues in the Bahamas, and there's no specific obstetric medicine specialist. The antenatal patients usually attend, these are the low-risk patients, they usually attend the community clinics, which are usually run by non-specialists. And there is a referral pathway for high-risk patients to be seen by specialist obstetricians at the Princess Margaret Hospital in Nassau. Barbados, so this is where our Cave Hill campus lies. There's 4 teams at the Queen Elizabeth Hospital. You see the British links there to our British colleagues, Queen Elizabeth and the Princess Margaret Hospital in Nassau. So at the Queen Elizabeth Hospital, where I worked for about a year and a half in Bridgetown, the team see their own obstetric medicine patients, including gestational diabetes, patients with epilepsy, kidney disease, etc. There is no specific or separate obstetric medicine clinic. However, there is a trained maternal fetal medicine specialist, and she will see high-risk and ultra-high-risk patients following their own local protocols. In Jamaica, again, most antenatal patients are seen in the community with specific referral pathways to tertiary centers. There are 2 maternal fetal medicine specialists at the University Hospital of the West Indies at Mona, commonly referred to as UC, or the University College of the West Indies. There is a ultra high-risk maternal fetal medicine clinic, and these are run by trained subspecialists. They had their training in Canada, I think, and they are now based at the UHWI. Again, no specific separate obstetric medicine clinic. Trinidad and Tobago. We do have comprehensive guidelines which have been produced by the Ministry of Health under the Directorate of Women's Health. Of course, we have Adisha, he's our director. The running joke with him and the minister, anytime they give a speech, the minister will always say he is the first director of Women's Health, and he has done a significant amount pertaining to women's health in this country. These include guidance on management of in pregnancy of hypertension, diabetes, certain hemoglobinopathies, as well as others. We have 3 major referral centers: Port of Spain General, Mount Hope Women's, and San Fernando General. Again, this is one of the examples of the protocols that Adish personally would have done. And again, we must give tribute to Adish. You have done a remarkable job of and the impact that the Directorate of Women's Health has had on overall healthcare for women in this country. So I congratulate you, Adish. Right, so in Port of Spain General Hospital, again, no specific obstetric medicine specialist. They do, however, hold regular MDTs along with physician colleagues to discuss high-risk and ultra-high-risk patients who are seen in the general antenatal clinic. No separate obstetric medicine clinic are held. San Fernando General Hospital, where I work, no obstetric medicine specialist again. 4 teams in the department, and each team will be assigned a common medical condition. For example, my team will be seeing neurological cases, another team might be seeing cardiac cases, and another team might be seeing endocrine cases, but they are still seen within the general antenatal clinic, no separate obstetric medicine clinic. At Mount Hope Women's, no obstetric medicine specialist. Most medical high-risk patients are seen within the general antenatal population in those clinics. There is, however, the only separate medical antenatal clinic for diabetes in pregnancy due to the high incidence of diabetes in pregnancy. This is consultant-led, so this is quite impressive. That's being done in Mount Hope Women's, and it's consultant-led with input from endocrinologists, ophthalmologists, diabetic nurse, and others. And these are usually in the clinic on the day that our clinic occurs. And patients received glucometers, test strips, and this is also done in other hospitals as well too. This is, again, a very recent initiative by the Directorate of Women's Health. So what should we do? We have recognized the need for these specialized clinics. We will need to tailor our needs, to our needs and population size. We do have a smaller population than the United Kingdom, and a separate clinic may not be something that we will be able to afford. Maybe a centralized obstetric medicine clinic or a roving obstetric medicine specialist to move from clinic to clinic on specific days. These are just ideas that we could develop. This is some of our team. This was during our recent MBBS exams. This was taken in Bahamas, and we have colleagues from the Bahamas, Jamaica, Barbados, and Trinidad, of course. And this is what we do here. This is not what we only do here, Kathy, but we of course partake in these are the local this is the local Bahamian beer. Who knows where this is? The Trinis. Do you all know where this is? This is the Pitch Lake, and as Professor Nelson Percy there yesterday at the Pitch Lake in Trinidad, enjoying the very, very hot weather. This is Professor Nelson Percy. Is it Sonji? Sonji is there, Melanie is there, Vanessa Harry is there, and Sharon is there. Yes, Sharon came a bit late. She did. You did? You joined us for lunch when we were having dessert. Right, and I end here. Now, who knows who this is? Sharon, you want to tell your colleagues who this is? Right, so this is Marshall Montano. And of course, the reason I put this here is not because it's carnival. It's because Marshall Montano has decided to take a break this year from carnival. So he's not really performing, although he did perform in Calypso Fiesta. But he's taken a break because he's taken some time off to do a master's in carnival studies. And it's very important that we do this because I am a stickler for being qualified, making sure you know what you're doing when it comes to a certain specialty. And Kathy also pointed out you want to get that piece of paper at the end of it. And certainly Marshall has, set that example. So he's not just about partying and soca, but he's about setting an example to our children as well, and our specialists, that you must get that qualification, you must get that piece of paper. And kudos to him, and kudos to everyone here tonight as well, too. To the rest of the team, thank you very much.